Okay, so now it's being recorded. Okay, so for each hour of class time, a 10-minute break will be given. So if I'm in the middle of something and you guys see that it is 2 o'clock and I'm deep into what we're talking about, somebody interrupt me and say, hey, it's time for a break, okay? I don't mind that at all. Now, let me kind of say something about this. We're not supposed to have food or drink in the classroom, and we do allow for that as long as we don't find things on the floor. Like yesterday, I found some, I don't know whether someone was eating some type of candy or gum with a couple wrappers, and I clean off all those desks and everything afterwards, and somebody has to pick that stuff up. So if you're going to be eating something in there, some of you may need a snack during these long clinic days. And when we're in that classroom, mostly we're going to be inside the clinic. And that is true. It is a very strict rule that we cannot break about not having food in the clinic. Okay. And having the students having water in there. That's an OSHA rule. So those carpets don't get, our building is owned by Metropolitan College. And so we have to just be glad, they have someone come in there and clean, but they don't always do the carpets every single day. So with this COVID thing going on, I don't know if they are now, but at any rate, if you're going to bring something that's crumbling things on the floor, you need to stop and pick them up before you leave, and shouldn't really have much that crumbles on the floor. But I don't mind if you have something to drink in the classroom or to snack on something at all. So I can kind of get around that, but it's an absolute no-go for the clinic. We're not supposed to, but we've kind of been able to get, these classes are just so long. So we are aware of that. So students spend numerous hours preparing for each class, and students are expected to read and preview the assigned material prior to the class meeting for which it's assigned. Attendance policy, online education affords students great flexibility in managing their time. However, success requires that students engage in the learning activities regularly and participate in meaningful interactions with faculty and fellow students. Specific daily attendance is not required for online courses as it would be on campus. Students are required, however, to log into their class regularly and submit assignments in a timely manner, or they may risk being withdrawn for lack of attendance. So for each course, initial attendance is recorded when a student logs into his or her class and completes a learning activity. Students who only view the syllabus but make no other substantive participation for the rest of the course are not considered enrolled, and attendance in subsequent weeks is recorded by a student completing a learning activity. The act of logging in each week does not constitute attendance. The student must participate by either engaging in a discussion board or submitting a graded assignment to be considered present for that week. Once a student has logged into his or her class and completed a learning activity or assignment, he or she is considered officially enrolled in the course and expected to complete the entire course. Failure to post attendance for 2 consecutive weeks may be subject to the students to immediate withdrawal. Coursework is assigned weekly. Students are expected to complete assignments according to the coursework. Refer to the makeup work policy for submitting missed coursework. Students must show attendance within the first 3 days of the course, or they're subject to withdrawal from the course. Learning activities online. Students use the Canvas Learning Management System, or LMS, to view video content, receive and submit project work and assignments, take assessments, quizzes, and tests, communicate with instructors and classmates, and review course progress and grades. In keeping with the modality of online learning, much of the content will be delivered either with ebooks or digital content. Successful online learning requires the student to be active participant in all learning activities, and those will vary by course, but they may include discussion thread posts, exams, quizzes, and assessments, case studies, group interactive assignments, and other graded assignments. All learning activities associated with the course will be clearly outlined on the syllabus page within each Canvas course. Attendance is recorded when the student submits any learning activity, and students must contribute weekly to discussion forums. That's if your class has them each week. Excessive time absent will prevent a student from achieving course and program outcomes. For the purposes of this policy, excessive absences are defined as missing more than 10% of total scheduled time within a grading period for programs that include clinical hours. A student may be placed on attendance warning at the end of the first grading period, which he or she has excessive absences. A student will remain on attendance warning until the end of the following grading period. At the end of the following grading period, a student who did not have excessive absences will return to good standing. Attendance probation. A student will be placed on this at the end of the grading period during which the student was on attendance warning and had excessive absences. A student will remain on attendance probation until the end of the following grading period. At the end of the following grading period, a student who did not have excessive absences will return to good standing. A student on attendance probation will be withdrawn immediately upon having excessive absences. Clinical participation is vital to your success, and you're expected to be present on time and prepared for every scheduled clinical experience. If for any reason a student will be late or absent for a clinical shift, the student must notify the instructor or other designated Concord individual immediately upon becoming aware of the situation. Except in the case of documented emergency, failure to notify of an absence or tardiness at least 60 minutes before a scheduled start time, or arriving more than 30 minutes late to a scheduled clinical shift may result in disciplinary actions up to and including withdrawal from the program. Students who have any absence or absences that result in not completing the required clinical hours, lab competencies, or required cases shall fail the course. Clinical makeup sessions may be provided. However, the program's ability to provide makeup hours is dependent upon scheduling and other factors that may prohibit the availability of clinical makeup hours. Any missed lab or clinical hours must be made up. Case-based activities will be assigned to the lead faculty or program director, and completion is required for progression into the next term or graduation. So I'm going to add a little something in here, even though it states it. It's really critical for you to, if you know that you're going to be late or absent or need a day off for something with a doctor or a family issue, emergency, whatever, or sickness. It's really critical for you to always send your lead instructor of whatever course that you're in, and also send to Director Beckerly. So you can send it to Director Beckerly and copy me, or the other way around. I don't care, as long as we're getting it. Okay, so missed work, makeup, all graded work, quizzes, tests, homework, projects, papers, etc., or perform competencies not completed by the due date or missed due to absence, including being tardy or leaving early, will not be eligible for a grade. Students will receive a 0 for missed classwork. Students may request extensions for graded work not submitted by a deadline if a significant and documentable event prevented the student from submitting the work. The student must submit the extension request to the instructor or campus academic staff not later than 48 hours after the original due date. Students with advanced knowledge of a significant life event that will interfere with due dates may request to complete assignments in advance of that due date. Advanced submission will only be accepted with the prior approval of the course lead instructor and either the program director or academic dean. But don't just go to the academic dean or the director if you need this without letting your lead instructor know, because they're in meetings when we're in class all day long. We don't always have the capacity to get back and forth with this information, and then we're not happy. So make sure that we get it. All work submitted prior to the due date will be accepted without penalty. Assignments will only be accepted during the first 5 minutes of class. The student will be responsible for adequate preparation for class. The students will bring any needed materials to class and will be responsible for assignments that are given on a handout. Test taking days, on examination days, quizzes, midterms, finals. Students can be seated in an assigned seats. All backpacks, purses, and any other belongings will be placed in the front of the classroom until after the examination. Tutoring can be arranged for any student who demonstrates academic need or requires additional help. If a test score below 75% is received on any examination or midterm, mandatory tutoring will be scheduled and must be completed within the following week. So let me say something about this. Sometimes we're teaching both cohorts. We're in the classrooms trying to get that all done, and we're also in the clinic with patients. So we see when we're putting the grades in, if someone has failed a quiz, but we're adults, we're not, like I said, in middle school or high school situation. So if you have received lower than a 75%, totally expect you to take the initiative and email your lead instructor of whatever course and say, I know that I did not do well on this test, and these are the times I can meet, get back to me, we'll schedule a time. So it's difficult for us to chase down all these people because we're already chasing people down trying to get things signed and et cetera, et cetera. So take the initiative and go ahead and let your instructor know, and then you can schedule a time. Grades of incomplete. The policy for a grade of incomplete is found in the college catalog. Office hours, instructors will be available to meet with students by appointment. In respect to all instructors and curriculum confidentially, students are not allowed in the faculty prep office, in the prep room. Cell phone use, including text messaging, is not permitted in the classroom nor the clinic. Therefore, phones should be turned off and placed out of sight. Now, I have a few comments to make about these last two things, especially since we are in the COVID thing and we're online doing a lot of things. First of all, office hours, they're trying to keep people away from, social distancing. So on days that we have sometimes a class like we're having right now, then it's like you're not going to be in clinic that morning, so work at home. They want us to kind of stay home. So that used to be some of the time that we could schedule a one-on-one meeting if a student just wanted to discuss something with us or go over a test. So that kind of has been taken away. But I am more than willing and have done a lot of it. If a student wants to just meet me and just talk to me about whatever, classroom related or personal related or something like that, test related, tutoring, you can always email me and we could set up like a one-on-one situation on Teams and, take 10 minutes or half an hour or however much you need and get that done on Teams. I'm perfectly fine with that. And really, if you're having difficulty understanding something, I'd rather you do that than just keep that, because everything builds on something else. So if you need to have something explained to you and you've done a little bit of research yourself already, you know, in the book, and you are not getting it, I'm more than happy to help you out. Cell phone usage. When we're over there in, like we were in 511, some of you have kids, you have kids in school. Some of you may or may not have children, but you've got doctors that are, or nurses that are getting back and forth with you, maybe about tests or appointments. I get it that sometimes you need to take a call when you need to take it and schedule something. I am not opposed at all for if we're over in the classroom and you get an emergent, you know, a call that's really super important, for you to take that call and just go outside the door. Just come up to me after class and let me know what was going on. I don't mind that at all. This is mainly for people who they're in the classroom and it always starts out real good, and then about the third or fourth week when you're speaking, you see their eyes just completely down because they have their phone on their lap, as if we can't tell what what they're doing. So that's the kind of issue won't be tolerated. So other than that, I don't mind if you have them on. However, you're not supposed to have them on or bring them into the clinic. So I would say that if you are expecting a certain call from your child's daycare or your husband over some test or some whatever that's kind of important, doctor or something, just come up and tell me, and I'm sure I will say you can keep your phone in the but that way it looks like you're not just trying to sneak your phone, like everybody gets what's going on. And then the rest of the syllabus is going to be in the all these assessments. So they're scored like 2, 1, and 0. And then there's a numerical formula. 2 being satisfactory, you did everything satisfactory. A 1 which is 100. If we have to put a score on it, you could put pass, not pass, fail, not fail, satisfactory, unsatisfactory. But they want us to have grades for that. So if you have a satisfactory, you're getting 100. If you have something where we're like, they're not really getting number 6 and 7 or something, we may put a 1 on those that you need improvement. And then we'll just figure we'll add up the points and do it that way. Give you a grade of maybe you get 90 or whatever that equals out to be. And if there's too many of them, we're just going to mark it as 0, unsatisfactory, and that you remember that you'll have to do it again, okay? Because we can't just say that's unsatisfactory, now let's move on. I don't want to leave anybody behind, and so you'll have to redo that particular assessment. Any questions on that? Okay. Any questions on the whole syllabus?
No, not really.
That doesn't sound convincing. Is there some or no? No?
No. No.
Question? Okay. All right. So I am going to go straight into the PowerPoints. Did you guys kind of decide as a group? I know there's 24 of you and everyone's going to have a different idea. I thought what would be a good idea is to, I hope you have a copy of the study guide. And as we're going through these, you're going to be finding your answers, and we can kind of do it that way. Is that agreeable?
Yes.
Okay. So Okay, so can you still see that? Yeah, okay. Chapter 1, the professional hygienist. So it's a licensed primary healthcare professional, oral health educator, or clinician who provides preventative, educational, or therapeutic services supporting total health of a control, oral diseases, and promotion of health. So that's kind of just a definition that you don't have to memorize, but it's something that is pretty logical and just kind of would make sense that way. History of hygiene, you've probably already heard of this guy's name, Alfred C. Fones, 1869 to 1938. He is the American dentist from Bridgeport, Connecticut. He's the founding father of dental hygiene starting in 1906. And I see this question in review books. There's always at least one, making sure you know who Alfred C. Fones is. So he created the name Dental Hygienist, and in 1913 started the first school of dental hygiene, and he trained his chairside assistant, Irene Newman, who was the first hygienist. So I've also seen that question, who when they want to throw something in there that they don't know if everyone knows, they'll say, who is Irene Newman, or who was the first hygienist? So you might kind of stick that back. You're going to be hearing, I think this is part of the introduction of so many of the courses we have. So hopefully, I'm not real sad about that, because hopefully it will allow it to sink into your brain to remember. He's the one that claimed that public education is the primary goal of a dental hygienist. That's the whole reason that he started the dental hygiene, because decay was rampant in 1913, and not everybody went to a dentist. There were a lot of immigrants, a lot of people didn't have the money, and they didn't really take care of their teeth that well. It was not uncommon for people to have a lifespan of maybe 40 or 50. People were passing away. Obviously, some good amount lasted until their 60s, 70s, or 80s, but without great health care or oral health care, it was not uncommon at all for people in their 40s to already be a dentalist. So he saw the huge need for the community, and he thought, if I could have a person that in here that knows what I'm doing, that can go out and educate the public on when to brush their teeth, even, and the use of a toothbrush, etc., that it would cut down on this tremendously, and he was correct. So he started the first school in a carriage house behind his garage. He got his pals who were instructors from Yale, Harvard, Columbia, top-notch guys, to name a few. And the first graduating class was 27 hygienists, Irene Newman being the first. So there are 6 roles, professional roles of dental hygiene. There's a lot of different avenues that you can take, and you can be an educator. First, the dental hygienist, let's start with that in the middle. Dental hygiene should always, no matter what role that you have, should always be interested in the public and community health. So that goes without speaking, but you could be the clinician, and that's how you want to spend your life: an educator, researcher, administrator, or manager, or an advocate. Just an advocate that maybe goes to the state and lobbies for people to be able to get benefits or access to care or fluoride. So there's 3 things that in dental hygiene care: preventive services, you have primary, secondary, and tertiary. And I always put, need to tell you this, I always put things, not that other things aren't important too, but things that I know that I've seen questions about in review books, etc., in red or maroon or another color. So that's why that's that way. And primary measures, preventive services that we do are measures carried out so that disease does not occur. For instance, home care instruction. That would be considered a primary preventive service. Secondary treatment is really where most of us lay. That's early treatment of disease to prevent further progress or of irreversible conditions. So irreversible condition would be periodontitis. Gingivitis is reversible, so that wouldn't include that. But for instance, scaling and root planing is irreversible. What you can maintain it and stop it in its progress is what would the goal is. But scaling and root planing would be early treatment of disease because they've already got the disease, and that's really key. Then there's a tertiary, which is what the dentist is. There's a third rung called tertiary, where they replace lost tissues to near as normal, try to get it back near as normal as possible after a patient has had a secondary prevention. And after that prevention has just been unsuccessful. We've scaled and root planed as much as we can, and it is still going downhill. Then they may need to remove the tooth or put an implant or a bridge, etc. Preventive services continued. You have educational services, and we educate to elicit a behavior change in a patient. We want to educate them on using a soft toothbrush, brushing before they go to bed, when they get up in the morning, etc., because we're hoping that their behavior changes. Therapeutic services, this is a treatment that we will give a tooth to try to arrest it or stop it, is what that means, or to control the disease. So sometimes we have, those of you who are assistants probably know of this, there are some therapeutic, which means there are different types of treatments that you can try to get to close a pocket. Some are made of powder, some are little, it's an antibiotic that's placed on a little chip. You'll be learning about all these later, that we put down in the pocket, and they're time released. And so to try to control the disease or stop it where it's going, and those would all be therapeutic. So
Quick question for you.
What?
Quick question for you. Is this the number 4 on the study guide? It says know the categories of prevention. Is that the primary, secondary, and tertiary that you just went over?
Yeah.
Okay, perfect. Thank you.
Sure is. Yeah, that's a good thing. Just stop me when you come to those. Okay, which of the following is secondary prevention?
B.
Right. So it'll be B, and it will give you, it's not a true prevention or primary prevention or where no disease is present. So you can't have, if there's no disease present, you can't have secondary prevention, in other words. So I always see it listed as treatment of early disease. I don't see it really described as anything else. Tertiary would be what the dentist does, and primary is just education. So process of care. Process of care, you're going to hear over and over in a lot of your classes because that's what we do. The ADPIED that is in red stands for, is an acronym. It stands for assessment, diagnosis, planning, implementation, evaluation, and documentation. So that's the first letter of each word, and we just call it ADPIED. Every patient that you get is going to be on this. Like right now, in what you're going to be learning, now that we get the hand washing and the sterilization down and the cleaning of the cubicle, etc. down, when you start with the blood pressure, you're starting with the assessment type. You start with the blood pressure and actually the medical history also, which we'll do next week, because now you're gathering information. We need to gather information first. And so we're going to take their blood pressure, we're going to get their medical history, we're going to do their charting of restorations that they have, maybe treatment that they need, filling or something, we're going to take their perio pocket readings. We're going to take all of this information and x-rays, and then we're going to gather it together, because if we need all that information to make a diagnosis. So the assessment, you'll be learning all the assessment things, and that's why you're going to be learning, and your assessments in clinic are running right along with this. After we diagnose it and we actually give a diagnosis of what they need, they're a healthy patient. They can come back every 6 months. They need deep cleaning, so I'm going to set those appointments up. Or they've had a deep cleaning and they really need to come back every 3 months. So then you plan from your diagnosis of what kind of treatment they're going to have. Then you have to actually implement it. The patient has to come back and you have to actually do whatever you've planned. Then after you do that, you evaluate it. And we can't just keep giving people, we've given people, like, retreated them for scaling and replaning, but you cannot just keep doing that. Like, you can do it twice, but we don't do it 3 and 4 and 5 times. If it's not done, we don't see rapid improvement by the 3rd time, then they come back. We send them to or refer them to a specialist. And if the specialist can't take care of it, or they don't go, then we just maintain them.
I have a question about number 12 that applies to the process of care. Is there anything else that you think we need to add to that? Because it says list the dental hygiene care in order and know the acronym for it, but you put in bullet points in bold below it the acronym and the process of care in order. So do we need to add anything to that?
No. Just on some of them, I gave you the answer.
Okay.
Okay. So then we evaluate it and see how it did, and if we need to refer them out, or we need to redo, or what we need to do. And then, of course, nothing is, if you don't document it, it didn't happen. So especially in a court of law. So everything we document. So what this does is it provides a framework for that patient's individual needs, and we identify factors that may be causing their condition, and maybe we can help reduce that or eliminate it, or something that we can prevent altogether. So maybe they can prevent all the loss of tooth surface that they have because they keep grinding their teeth if we just make them a night guard. Okay, so sometimes we can prevent things. Here's something that I want to just, we'll be talking about it again, but a dental hygienist legally cannot diagnose. It's the dentist who diagnoses. But what we have to call our diagnosis is a dental hygiene diagnosis. So we'll say DH, a diagnosis is, acronym is DX. So we don't have to write the whole word out. So we'll say DHDX, a dental hygiene diagnosis is. So, and I'm quite sure they'll probably have something about that on boards, because they're very big on that. Okay, so application of the care plan, the components serve as our foundation for clinical practice of all of dental hygiene. Everything is about the process of care. Dental hygiene process of care is ADPIED. Effects on oral health status, increasing diversity of ethnic or racial communities and linguistic groups, cultural learned patterns of health and knowledge, influences of culture, affects people's beliefs and their behavior. Cross-cultural communication, we try not to stereotype the beliefs of any cultural group. And the professional dental hygienist has respect for each patient's cultural differences. So I'll let you just go through this, or we'll never get through any of that, but you can go back and kind of look through the question answers. Our ethics, the purpose is to provide general standards of right and wrong. That's what ethics are, that guide our behaviors. And so when we become dental hygienists and get a license, we have to agree to a certain code of ethics. And so you will study a little bit about it now, and then in your 5th term, I'll be teaching you dental law and ethics, that class anyway. So what it is, it's going to describe professional conduct. And the ADHA, which is the American Dental Hygienist Association, and the CD, that's the Canadian Dental Hygiene Association. And this is an international federation of the dental hygiene members. I mean, everybody, we all have a code of ethics. Dentists, the ADA has a code of ethics, so you can always look up there. So the core values in dental hygiene are respect for the individual, confidentiality, societal trust, beneficence, nonmaleficence, justice, fairness, and veracity. So what the biggest one is nonmaleficence. That's the founding code. That's all, way back from Hippocrates, and is part of the doctor's Hippocratic Oath. It's non-maleficence, which means do no harm. First and foremost, we have to do no harm to a patient. The patient is always first. So ethical duty, it's like you keep learning as society is changing what is considered ethical and not. So it's a lifelong ethical duty, and you provide evidence-based patient care. We don't just say, we do it this way, and my doctor has prescribed it this way forever, and that's why we're doing it. Okay, so we need evidence-based scientific evidence that something is correct, not just because the representative of some product company came in and told us and has all this stuff to back. We have to make sure that it is scientifically evidence-based before we start telling our patients what they need to do. So overall goals, you aid individuals and groups in attaining and maintaining optimal health, exemplify the highest degree of professional ethics and conduct, and then you document. So we need to write objective, factual information that respects the patient, the practitioner, and your practice. We do not put anything judgmental in our notes. If you want to keep some separate file about your patients in some kind of like a recipe box, and you have them alphabetically on index cards, like, you know, this patient has the 5 kids that all go to all went to Notre Dame and just had their first grandbaby, you know, that kind of stuff. You can keep a separate file, but none of that stuff belongs, of course, in the notes. Nothing personal. They need to be accurate, comprehensive record of all aspects of the care we give them. So that would be, any questions over that? And now we're going to talk about the evidence-based. So the main goal of dental hygiene is to improve and maintain the oral health of the patient. We need to use the best scientific evidence available to make our decisions. And it is a formalized approach that we gather from the assessments that we get from the patient. So evidence alone is never sufficient to make a clinical decision. So just because I get all this great evidence that we're supposed to have, that something the patient should be doing a SRP, if that patient is not going to do the SRP, I mean, we can't, it has to fit in their needs. Okay, so it's something that we have to collaborate for the individual patient's needs, and then back what we are ethically, what we know to do, and then have evidence, scientific evidence to back it up. And that's what it's meaning. So just because we do have this great evidence, it's not enough to make a clinical decision. So the purpose to answer clinical questions, we quickly and efficiently identify research supported best practice interventions, and that contribute to a patient's positive outcomes. There's always articles by the ADA, ADHA, American Dental Association is ADA, Hygiene Association is ADHA, to ensure application of the most up-to-date practice interventions in the delivery of patient care. So the need, and let's talk about the internet. Patients becoming more sophisticated about researching the internet and for health information. Most people now diagnose themselves. They see their what's going on, and they will get on the net and start diagnosing, and it may not be anything of reality. So they're going to expect you as a graduate to know what the latest developments in oral care or health care according to your oral health, and they're going to expect you to know them. So that's just a way of, we need to keep up. It's if new things are coming out, a new way to do something, and they ask you and you go, I don't know. And that's what nobody knows everything. But if you keep saying that and don't kind of keep current on your own time of new developments, then that can not bode well. So clinicians also, we are not consistently knowledgeable about every single new therapy out there. We've graduated, we're working, we're families. There's so many magazines that you can get about all these. There's no way to absorb it all. But if you can keep in a dental hygiene, join the Dental Hygiene Association from your city or your state, that will keep you kind of current, and take continuing ed classes that are kind of current out there, and you'll get this feedback from being in these associations. That's a good thing. So a gap in the knowledge of up-to-date care widens the longer time that clinicians have been out of school. So when you graduate, you're going to have the latest information that is out there. Okay. So you're going to be you're not going to have the experience part of it, but you're going to have the information. Other hygienists in your practice, they'll have some of it here and there that they have gotten at CEs and keep up on things that way, but it's not like being in school, the amount of time that like you guys are learning in school. So the longer that they're out of school, that knowledge of latest things going on is going to widen. So you really have to keep up with new things. Skills needed for ABDH means evidence-based dental hygiene. There's a variety of tutorials. You need to follow a systematic approach, step-by-step, instrumentation, as well as overall treatment. Read and understand research. Practice helps us recognize reliable information versus unreliable. Be computer literate. Develop a critical thinking, and which is necessary for us to evaluate all these things that are coming across the internet. Embrace self-directed learning with your continuing education courses after you graduate. Then there's PICO. Some pronounce it PICO. I've seen this in review books, but I don't believe I have questions over your quiz. But it's about asking questions. A good researchable question has 4 parts. The P stands for patient problem or population. Like, what are the most important characteristics of the patient population? Intervention. What main intervention, prognostic factor, or exposure is being considered? Like, let's say this is about you wanting fluoride in your rural county where you come from. So you need to say, what's the problem? What's the population? What are the characteristics of the population? How much decay do they have that they would need this fluoride? An intervention. Which main intervention would you like for them to be exposed to? And then try to find an alternative, a comparison to what might be an alternative. And then you come to the outcome. What's the desired outcome, accomplished measurement, or improvement effect? How am I going to know when if we put fluoride in, if it worked or not? Okay, so that's PICO. This is what I want to search for evidence. Google and Wikipedia may lead to some results, and they may lead you to evidence-based material, but accuracy and unbiased sources you cannot be assured of. PubMed, Medline, provides scholarly articles and other health-related journals, so we use that in the clinic a lot. The American Dental Association's evidence-based website is good. The National Institute of Health, those are all reliable sites, and now with this COVID, it may have been taken down, but it used to be posted on the wall above a computer outside of Beckerly's office. She was Sanchez. I need to change that. Now she's Beckerly. Then you need to determine the purpose of the site. .edu and .gov are considered reliable sites for educational and governmental information, so those are good. .org indicates it's a nonprofit organization. Okay, so you need to understand what the mission and purpose is of that organization, because it may be biased toward that particular organization. .com, .biz, and .net tend to be special interest groups or advertising, possibly for profit. So you need to understand why they may be coming up with the conclusions that they're coming up with. So you just need to be a little savvy about not believing everything. I see that it is 2. Do you guys want to take a little break? Or do you want me to go on? Anybody?
You can go on. Yeah,
Me?
after chapter 3.
Okay. Okay, so chapter 3, effective communication. This is it's a good chapter, but it's all based around it's kind of redundant. So I picked out a few things. We need to develop communication strategies, and at first some of you just may be naturally good at it, and some it's going to be it's a progress, okay, a learning progress, and how you deal with people. And people, you can have a great way of communicating with someone that 90% of the patients just adore you over, and darn if you won't get that 1 or 2 patients who don't like the way you communicate. Okay, so you can't please everybody, but what it's meant to do is provide patient-centered health information, so that some of the information that you give them you'd also give a broad group, but we need to center on things that make that certain individual's case better. So we also are trying to motivate positive change in health behaviors and achieve improved health outcomes. So you can interview and role model. You're always assessing your patient's readiness to change. There's nothing worse than a patient who they're having a bad day maybe. They come into your office to get their teeth cleaned and to relax from all the woes in their life. And they get this real peppy little, hygienist who it just wants to rock their world with all the great information about that they have gathered at some CE. And this patient doesn't want to hear anything. And so they're getting very annoyed. Like, I can't believe I'm 55 and I've got this gal that's telling me, guess what? It's really important to brush your teeth. Well, duh. And so they'll get, they feel talked down to, and they will get annoyed. And so you have to assess kind of where your patient is and how they're going, if they can change their behavior. Some people that have special needs, that if you notice that patient is not moving their left arm very well, and they're left-handed, then don't go on a tirade about how they need to brush their teeth a certain way and in a certain angle. They may not be able to do it. So we have to always be building relationships and understanding where they're coming from in order to, and then try to find something to fit it. So we need to pay attention to their attitudes and beliefs, and personal attributes of confidence and flexibility. So we need the evidence-based, accurate, balanced, and reliable information. We need to be consistent information, even if see it from other sources, culturally and linguistically appropriate. We need to deliver it in a way that they can understand it and that's they can actually do. It doesn't do any good to give the best flossing demonstration to someone and then not let them try it. They go home and go, okay, and then they try to put it in there. They're not holding it the right way and they get frustrated. It's now stuck in their teeth. They just take it out. Any of us would take it out of our mouth and we would throw it in the trash can and there that would go. So you've got to, if the patient you can tell is kind of ready to receive it, then that would be a good thing. And there's certain things need to be repeated and reinforced over time. We need to watch our verbal and nonverbal communication. We need to watch our tone, our sarcasm, our inflection, the volume, how loud we're speaking or how soft, and the tempo that we're speaking. So not everybody gets, some people die laughing at somebody who's funny and real sarcastic, and other people are really put off. So in the office with your patients, you need to watch that and be funny on your off time. Nonverbal, you need to watch your eye movements, body positions, your grooming, your facial expressions, which they cannot see much of, and your appearance. If all they have is to look up at your face, if they have their eyes open. So if they look up and what they're seeing is, they can tell you haven't washed your hair for 4 days. It's nice and greasy. You've got mascara underneath your eyes. Nobody goes in there like a beauty queen, and nobody looks like one anymore either. So if not that we ever did in hygiene, but now we have this mask. It was important before. It's majorly important now, that if all of a sudden they open their mouth and we see this like really gross pus coming out of their tooth, that you don't all of a sudden open your eyes like saucers. So don't wear your heart on your sleeve. We've got to be professional. You may be thinking that inside, going, oh my God, what is that? But we can't let our eye movements betray us. So they talk about a locus of control. I have seen this, not very often, but I do see this. It's like, what does locus of control mean? And what it means is it's based on the perception of personal control over health issues. If someone has an internal locus of control, they believe their personal actions determine what their health status is. If they have an external locus of control, they believe that their health and illness are determined by external factors, and that if they change their behaviors, it will not really have a positive effect after all, okay, or overall. So that's the external kind of blames the outside forces for their health, and the internal kind of takes the bull by the horns themselves. So to make a behavior change, people need to believe first that they're even susceptible to the condition. Just like masks during this COVID, we've got groups of people that don't even think they're susceptible to this condition. Masks don't do anything. They're not going to believe in doing something if they don't even believe first that they would be susceptible to periodontal disease or gingivitis. Like, I've never done anything that you're asking me to do, and I've never had gingivitis. So why are you putting me? I'm not doing what you told me. Okay, so you can have that. To make a behavior change, they need to believe that there's a serious threat to their health, that the condition can be prevented or even just arrested, stopped where it is and maintained. And they need to believe that they're capable of the actions that can make the change. So traditional versus motivational interviewing. Everything's about motivational interviewing. That's kind of the buzzword these days. Buzz phrase. Traditional is persuasive. Similar approach for everybody. We assume the power role as clinician. We do most of the talking, and sometimes we can get a behavior change by guilt, intimidation, or scare tactics. Motivational changes are very supportive, understanding, builds trust. We engage in a dialogue with them. We respect their autonomy, which is the right to make their own health decisions, and we direct it toward them. That can be motivational. Cross-culture communication, we need to follow a patient's lead for touching their personal space. Touching them or coming into their personal space. Use hand and arm gestures with caution. Sometimes doing the hi with one hand versus another hand. In some countries, third world countries, they wipe their butts with their left hand, maybe with a leaf. And so if you go and extend a how do you do with your left hand, that is a huge insult. Okay, so there are things like that. We used to a lot more actually, but we get people from other countries in our clinic. So we need to follow their lead as far as everything, and kind of use arm gestures with caution. Be careful in interpreting their facial expressions. There are some cultures that believe it is extremely rude to look at a person in the eye. That's a big show of disrespect. So if you think your patient you're trying to talk to them and they just keep looking down, don't take it like we all do, that they don't care what I'm saying. They want me to shut up. They may want you to do that, but they may not. So you want to simplify your language without speaking down to a patient, and follow their lead for making the eye contact. You can always use pictures and diagrams and demonstrations, and we always ask the patient to bring an interpreter. So in many cultures, a person's health issues are considered to be a family problem, and they're not going to be completely honest with you on the medical history. Oops. Okay. We are going to skip to transmissible diseases. Maybe. Okay. So DHCP, you're going to see a lot. That's an acronym for dental health care personnel. Sometimes we'll call it dental hygiene care providers. It's kind of the same thing, but it actually is dental hygiene personnel. So what it is to protect patients, personnel, and others in the office or clinic. And the responsibility of it is the responsibility of the entire dental team. Work practices need to be put in place to prevent cross-contamination. So the entire dental team must organize and maintain a system for the sterilization, disinfection, and care of instruments and equipment. And it's not one group of people. The dental team must develop and maintain work practices for all appointments and patients' contact to prevent direct or indirect cross-contamination between the dental health care provider and the patients, or from the patient to the patient. So now we'll go to standard precautions. I would know this. It's a newer definition of the last few years. They always used to say universal precautions. But the universal precautions only focused on the risk of the transfer of only blood-borne things. Blood, gauze that was saturated with blood was the only thing that they were really having precautions over. And then the CDC, this is by the CDC. And so they finally recognized and put in writing that other body fluids besides blood carry infectious agents as well. Your saliva, you know, the plaque, things that, microorganisms that are on your tongue, etc. It's not, doesn't have to just be from blood. So they changed the term to standard precautions, and they integrated, all they did was expand the elements of universal. So now we have a standard of care. And if someone says, what are your standard precautions? Because on every single patient, every single day, we need to give standard precautions. And if you're doing something wrong, you're going against standard precautions, is how they term that. You picked up a instrument off the floor and you put it back on your tray with everything that was sterilized. That is not standard precautions, okay? So they consider pathogens that can be spread by blood, all body fluids, excretions, secretions, all except for sweat, regardless of whether they contain blood, non-intact skin, or mucous membranes. So pretty much everything but sweat is considered, we have to always consider them infectious. So other precautions include airborne droplets from sneezing, coughing. It can transmit tuberculosis, influenza, chickenpox. Contact precautions reduce transmission of organisms and specific diseases by direct skin or indirect contact, like Staphylococcus aureus. Airborne precautions that we are hearing no end of now, which reduce the risk of airborne transmission of infectious agents. And it's all by this droplet nuclei. And so they're requiring special air handling and ventilation, for example, to prevent the tuberculosis aerosols. And of course, they'll be working on this for COVID. The microorganisms in the oral cavity. So you may have already had this in your one of your other courses. The origin while a fetus is in utero, the oral cavity is sterile. So within a few hours after birth, a very simple flora develops, which needs to develop. Then microorganisms are transmitted from the mother and other caretakers who are munching all around the baby's mouth, okay? And as the infant grows, there is a continuous introduction of more microorganisms that hopefully that they are building antibodies to become strong and healthy. So many of these bacteria come from the dorsum, which is the top of the tongue, mucous membranes, the gingiva, and the periodontal tissues. So an intact mucous membrane provides some protection against infection. That would be your mucous membrane would be soft, like the inside of your cheeks. And if you haven't bitten them and they're intact with no breaks in them, they have, of course, a certain amount of protection against your system. So disease-producing, potentially disease-producing, or non-disease-producing microorganisms may be present in the mouth of every single patient. And I know it says maybe, but I kind of think they are. Okay, so these pathogenic organisms may be transient, which means they can be spread from one place to another. So cross-contamination, I feel like this is on your, maybe on your study guide, is cross-contamination can be from person to person, person to inanimate object to another person. So I can spread it to another person, of course. I can also spread it to my pen because my gloved hands were in the patient's mouth and I went to the computer tray to write something down and I picked up a pen that's not wrapped and I do whatever writing, which now it's now on the pen and the paper, and then I put the pen down on the tray and now it's on the tray. And so I've picked up things from those three things also, and now I'm going to go back in the patient's mouth. Okay, so that would be person to inanimate object, and then back from the pen or back to a person. That's the 3 ways of cross-contamination. So this you're going to see also a lot of in your courses. And what it is, it's an innovation to break the chain of disease transmission. So this is how they're transmitted. First of all, like up at top, you have an infectious agent. And you see that right arrow up on top, and that standard precaution means that we use standard precautions on every single link in that chain. And so the infectious agent could be bacteria, fungi, viruses, protozoa. I'm not even sure. I'm pretty good with words, but rickettsiae, but rickets. Okay, so that whatever will be that infectious agent. And then in order for the infectious agent to have an effect, you have to have some type of reservoir for it to stay at. So that could be a person, it could be your equipment, your instruments, it could be water from the tubing, which is why we always bleed the water lines, for at least 30 seconds in between patients. We don't want any residue in those water lines, in the water tubing. So then maybe it's a reservoir, but now it's maybe on the instrument. And so now it needs a port of exit from its reservoir to you. So it could be in your saliva or blood, your skin or mucous membranes, or maybe you just sneezed and it's in droplets. Okay. And so if we're using standard precautions with the right kind of mask on it, that should not affect us. But we're not disposing of our waste in the proper way, our waste disposal. We could have a port of exit for whatever those pathogens are. Then you transmit it. So then you have to have it, you can transmit it now to direct contact, indirect, or it can be airborne. So then you sneeze, but now it needs to have a way to get into the patient. So they don't have a mask on, you didn't have a mask on, and they sneeze and they're going to breathe it in. So their port of entry may be their respiratory tract. Maybe it goes into their eye. Okay. Maybe it goes into a broken, skin or whatever, or like that herpetic whitlow that goes into the herpes virus, that if you have a paper cut or something on your hand, it now can get into your cut because you no longer have intact skin, which means there's no breakage on your skin. So you have to have some kind of maybe your GI tract or your mucous membrane. Your GI tract could be salmonella, something that you eat from all of this stuff, starting with E. coli. So after you have the port of entry, how we can, and the transmission, how we can try to control that and break the chain is by always using standard precautions and maybe control of our aerosols, which we're doing right now, and making sure that everyone is immunized. Okay, so that could help break the chain. But if it's not broken, now it's into the person. Let's say it's in the respiratory tract. And let's say they're a really strong, healthy person. Now, if it's something like COVID and real contagious, they may get it anyway, or maybe they'll just be a carrier of it. But you need a susceptible host in order for it to then become a further problem. And the immunosuppressed, the medically compromised, and elderly, and actually young children can be a really good susceptible host for infectious diseases. So we'll try to still use our standard precautions on these people, but this is to try to break the chain. But this is along each way, we can try to break that from becoming a real issue. So airborne infection could be dust-borne organisms. Surface disinfectant does help to control that. Aerosols are contaminants breathed into the lungs. Spatter, drop on objects and people. Contents could be single clumps of microorganisms. They could be combination. They could be single. Concentration is going to of the microorganism is going to be greater closer to the activities. So of course there's going to be more centered around the patient's mouth, which is the center of our workspace. So prevention of transmission, they've always done pre-procedural oral hygiene rinses or brushing or even flossing before you go into the dental office. They have now decided that it really doesn't do that much. It was always given to reduce bacterial growth and reduce bacteremia of going into the mouth because as you're scaling, sometimes there's some bleeding, and now there's an open entry, port of entry into someone's system of whatever bacteria is floating around their mouth. So the pre-procedural rinse, it doesn't do away with it, but they always claimed that it reduced bacteremia in the mouth and on the tongue. So you may still have that question on boards and still have it on tests that it does, even though just last fall they came out with now something that they don't think after 40 years of doing that it really does all that much. So interruption of the transmission, you can have the dentist can use a rubber dam, a high vacuum system, filters, ventilation, and have a relative humidity. Clean water, we want to run water through the lines for at least 30 seconds at the start of the day, after each patient, and at the end of the day in clinic. Now on your tests, I'm going to put 2 minutes because at the beginning and end of each day, because the reason we can do it 30 seconds at all times is because
Hello?
I think we lost her.
Uh-oh.
She's just gonna keep talking. Won't we all have to like exit out and then get back into it? Because she'll have to
Yes.
give us access. Oh my.
Is it still recording?
Yes.
Yeah. Yeah, it says it's still recording. Do you think we all should just end the call and try and resubmit?
Should we email her?
Yeah, I think we should email her.
Okay.
Okay.
She probably won't even see it if she's on a roll.
do you hear me?
Oh.
Yes.
Oh, there she is.
Okay. Yeah, I was admitting someone and accidentally hung up. So
Oh.
Wait, I don't see her. Oh, there she is.
There she is.
There you are.
sorry. No, I realized it immediately. Thank God.
Thank goodness.
Okay. So we can do it 30 seconds at all times, beginning, between patients, and end of the day. But if you don't have one of those vacuum flow back things, clips on your lines, the standard throughout the country and everywhere is to run your lines for 2 minutes at the beginning of the day and at the end of the day. So you'll run those by just pointing it at the sink and pushing the water down and just letting it flow out for 2 minutes. Or you can turn if you're not close to a sink, you can turn your high vac on and put that water tip right above the high vac and just run the water through there. So tests that I'm going to give, I'm going to, unless it says in our clinic, what can we run ours at? It's going to be, the answer will be the 2 minute at the beginning of the end of the day, because they may still use that one on board. So I want you to.
So on our study guide, it says at the beginning and end of each day and between patients. So it's 2 minutes at the beginning and end of each day. But between patients, is it still 30 seconds or is it 2 minutes?
Yeah, 30 seconds. 2 minutes at the beginning and end, and 30 seconds in between.
Thank you.
You're welcome. Okay, protection for the clinician. We know all about that. Use of masks, shields, protective eyewear can prevent direct control of spatter and aerosols in our face and eyes, and the use of protective eyewear prevents spatter and aerosols to their face and eyes. So pathogens transmissible by oral cavity, tuberculosis, viral hepatitis, AIDS, herpetic infections, and I guess we'll have to be making new textbooks and add COVID.
I don't see the PowerPoint on my screen anymore.
You don't?
No.
Okay. It may tick off because I have 3 monitors, so I have to kind of decide which one it's going to.
There we go.
You see it?
Yep.
Okay. Okay, now I need to open my screen back up. Okay. All right, this is what tuberculosis could look like in the middle of someone's tongue. So if you open, and you're seeing something like that, then that could also be a few other things. But that's definitely what tuberculosis could look like. It could have more than just that one. So as you're seeing that on your patient and you are going doing your assessment, you're going to be documenting that, and you'll come get one of the instructors. Or if I was at a private practice, I would definitely, say I need to go get some more instruments or something and run that by my dentist. What you're trying to make sure of is that you're not sitting there and you don't want to go through the rest of the assessments because it may be something that's contagious, like tuberculosis is highly contagious. Tuberculosis, you have drug-resistant tuberculosis, multi-drug resistant, and extensively drug-resistant tuberculosis. So this person needs to be in an urgent dental care facility that offers complete isolation. And so you're going to know that on the health history. Now, they may not know that they've contracted tuberculosis, but in the clinic never had this happen, or in private practice. Usually when people have, what you will have is that they'll say, I had tuberculosis 20 years ago, but I'm fine. That's okay. So you want to document that, and they're not contagious, okay? But anyone who has tuberculosis already knows they're not allowed anywhere else. If they're going to go, they go to a special dental care facility. Okay, let me get back on this page. Okay, so tuberculosis infection occurs most commonly in which area?
The lungs.
The lungs. Remember, you breathe it in. You breathe in all that. Yeah. Most commonly, it can occur in lymph nodes, kidneys, bones, skin, and the oral cavity, but the lungs are the most common. So these are droplets from our aerosols that we use, and maybe someone sneeze. These are the droplet nuclei that are suspended in the air, and some are much bigger than that. And the ones that are heavy, gravity's going to pull them to the ground. And the ones that are light can kind of stay in the air for sometimes hours, the really tiny, tiny ones. So you've got to have a ventilation system and suctions on. That's another reason that we, when we're on patients right now, the seniors, when they're doing a patient, they have to have their high suction on at all times, just pulling stuff out of the air, whether they're using it or not. So we're trying to control the any kind of nuclei suspended in the air. Use of an ultrasonic and other hand pieces and water spray can create aerosols that carry the tubercle bacilla. So droplet nuclei are small enough to pass through over 95% bacterial filtration efficiency, required of standard surgical masks, and may remain suspended in the air for hours. So that's why we have those standard ones are usually what was used because they're the cheapest. And people need masks all the time. This is before this COVID thing, but they've always had different levels. And that's why if we use the Cavitron, which we've been released to be able to do, but we have to do all these special things. You have to have a COVID N95 mask on and have a level 1 or level 2 at least mask on top of that, because they seem to think it's about layering now. So this is an ultrasonic. They are called Cavitrons or piezos. They're just by 2 different companies. And boy, does it remove calculus and really lavage or clean out the pockets really well. You will come to love these. Your patient a lot of times loves them because they don't have to stay in the chair that long. And so you use these in conjunction with your instruments, but you can see this, look at that aerosol that they create. So risk assessment should be conducted annually on a tuberculosis patient. Referral into the appointment. If you happen to have someone where they don't have it and they never did have it, but you're suspecting or your doctor is suspecting by oral things that they're seeing that they may have tuberculosis, you end the appointment, and if their symptoms are suggestive of a TB infection, and they're referred out. So patients suspected of active TB infection and treated only in a facility with an airborne isolation room. Now we'll go to viral hepatitis. HEPA, anything is liver. So itis is inflammation. So this is a viral inflammation of the liver. Causes could be viral or bacterial. Toxins and certain medications can cause this, and really heavy alcohol use. So the categories are A, B, C, D, E, F, G. And so I put them together according to what the route is. Your A and E are the oral fecal route. These are from your food handlers in the food industry with E. coli. And you can get hepatitis A or hepatitis E through that route. Now, B, C, and D are blood-borne. So you're not going to get those through the oral fecal route. You can only get those through a blood-borne route by contact with infected body fluids. So these directly impact us, but the risk is low because we use standard precautions. And so prolonged exposure, though, to an environment is necessary to be able to get that. So you may not get it because you were pricked one time with something that had blood-borne, somebody who had hepatitis C. Maybe you don't, but if you were doing that maybe a lot, like back in the day, a lot of nurses contracted hepatitis C because years later, these things kind of can lay dormant in your system. So the ones that were before they put, like nurses of the 70s, okay, and 80s, when they were using stuff, but they got stuck with needles and nobody thought it was a big deal, but they were getting stuck a lot, okay, as they were giving injections, etc. Then, 15, 20 years later, would develop hepatitis C. And they didn't even have, they had nothing for it, no cure for it. They do now. So they don't have an immunization for it still, but they do have a test for it, and they do have a drug for it. And that was just recently I want to say maybe the last 8 years or so, give or take. Prior to that, they had no drug to cure hepatitis C. So
I'm seeing you on my screen and not the slideshow.
You are not seeing the slideshow?
No, I'm just seeing you now.
Is anybody else?
I can see the slideshow.
In the slideshow.
I wonder if it kicked off when I went off. Can you go out of this and then come back in and I'll admit you again?
Yeah.
Okay.
I have a question related to the slide.
Sure.
On the review, it says know how hepatitis A and E and hand washing are related. So how would hand washing be related to that?
Because they were not, when they're transmitting E. coli through improper food handling and water.
Okay.
You can contract it because you've gotten bad meat with E. coli, but usually the oral fecal route with the food industry can also be because they're not using gloves, or they don't wash their hands. So if they need to be washing their hands or using gloves all the time, or they can transmit.
Okay, thank you.
So F and G. F and G are relatively new, and they are transfusion transmitted. So drug addicts, people who are sharing needles, tattoo artists that are not using safe standard precautions on people. These are usually to do with needles, and most of the time through IVs or drugs. So now we'll talk about hepatitis B. And so hepatitis B virus, or HBV, very serious. It's endemic. It can actually be, if it was not taken care of, it could wind up to be a pandemic, a global disease. We need use of very strict sterilization, aseptic techniques, and self-protection is absolutely mandatory to stay away from hepatitis B. And so, of course, now we have an immunization for hepatitis B, which is awesome. But hepatitis B can cause serious illness, cirrhosis, liver cancer, just a disability, and maybe even death. So it's transmitted by blood and other body fluids from a contaminated object. It could be from IVs, needles, sexual contact. Perinatal transmission means it could go from the mother to the fetus. A carrier, I think, I don't know what that was supposed to be, a carrier state or chronic hepatitis B. Immunity, develop antibodies after infection. So in other words, you could be a carrier or actually have it. So hepatitis B prevention, if they can do prenatal testing over it, universal immunization of infants and children, immunization of adults and adolescents, enforce the blood bank controls for the screening of all donors and rejecting those that have had a history of viral hepatitis, drug addiction, recent transfusions or recent tattoos, and travelers from HBV endemic area. So if they would screen all those people, then they could have a better control at the blood banks. So strict testing on all donated blood should for prevention. Enforce the use of disposable syringes and needles when you can, and especially for acupuncture, skin testing, body piercings, inoculations, to name a few. And to educate the public. There is a test against hepatitis B, and there is a vaccine. Okay, so hepatitis C. This is percutaneous. Cutaneous means your skin. So this is by skin by a needle, parenterally through an IV needle or intramuscular in your muscle, IM. Could be spread through blood, sexual contact with infected partners. So there is a test, but no vaccine. It's not a significant risk for us in the office setting. It can cause cirrhosis of the liver, cancer, and prevention and control. The best would be education and use of standard precautions. And of course, now there is a treatment, thank heaven. So hepatitis D is usually called the Delta agent. It cannot cause an infection unless you already have hepatitis B. So if you have, someone comes up and says they have hepatitis D, then you know that they've had hepatitis B. They had to have had it. Superimposed on hepatitis D is superimposed on hepatitis B carriers, multiple exposures to hepatitis B, especially patients with hemophilia and IV drug users, contaminated blood, body fluids, needles, sexual contact, and perinatal transfer can all happen with hepatitis B if they already have hepatitis D if they already have hepatitis B. So how do you prevent? By being immunized against hepatitis B, which protects from hepatitis D virus. So now we have the herpes virus. General characteristics: viruses are endemic worldwide. Each virus is causing many disease entities that are highly infectious. Up to 90% of adults have antibodies already to the herpes virus. They've already been exposed, usually in your youth or childhood, to the herpes virus. The herpes is what we call a cold sore. If someone says they have a cold sore or a fever blister, what it really is herpes. So it's lasting, those are just nicer words for it, and it can last up to 7-10 days, once in a while even 14 days. But they're fluid-filled blisters that open and they ooze serum-looking liquid, and then they crust over. So it takes those days for it to do all that. Herpes is a significant health problem due to lack of effective therapeutics and vaccines. They don't have them against herpes. There's only 8 strains of herpes that will infect humans. There's many more strains of herpes, but only 8 that can affect humans, and that's why we only study the 8. Herpes produce diseases with latent, recurrent, and sometimes malignant tendencies. So herpes is something that is, once it's in your system, like chickenpox, it lays dormant, usually in the nerves, usually in the trigeminal nerve, like chickenpox does. That is right up here. So it can lay dormant for years and years and years, and then all of a sudden something can trigger it, and it pops out. Stress can trigger this cold sore and fever blisters a lot, if that's the case. Most who get herpes virus 1 as an infant and child. There's herpes virus 1 and herpes virus 2. The virus can spread by skin-to-skin contact with an adult who even carries the virus. An adult does not have to have sores to spread the virus. You can be kissing a lot, eating from the same utensil, sharing a towel, drinking from the same water bottle in sports, which my kids did all the time, my girls. It used to drive me crazy. And even sharing a towel can spread the virus. So a herpes 2 is usually from sexual contact and can spread to the genitals during oral sex. So once you're infected with herpes, it never leaves your body. After the first outbreak, the virus moves from skin cells and then it goes to your nerve cells. And that's why it will house latent, which means it just chills out for a long time somewhere, and usually in your nerves, in the trigeminal nerve. The virus stays in the nerve cells forever. So it can be dormant for years or forever. It can become very active with triggers of stress, illness, fever, surgery, etc. So we reschedule these patients. We cannot ethically turn down patients that have like HIV or anything like that, but we can reschedule them because unfortunately with herpes or cold sore, whatever, the most contagious time is right before it shows up. So the patient may feel, if they've had them before, may or may not feel a little tingling or something in the area. And then the next day they can start with a little visible spot and then it can grow to much more. But you can see here where the trigeminal ganglion is, and it can just house there. And then you can see some stress comes up and it'll travel right down those nerves, right up to the lips and the oral cavity. So these are the divisions that we will be studying when we give anesthesia of the maxillary and mandibular, but that can also travel down those nerves. So it can also reactivate itself by ultraviolet light, like tanning beds, may happen, may not, or repeated exposure to the herpes virus itself. But these people, when it is highly contagious, and we will not treat while it's oozing, if we just see it come up and oozing. Once it's crusted over, it's not contagious anymore. But we will not allow you guys to treat those patients while it's contagious. And we've had to send people home and most certainly from the clinic. In relation to periodontal infections, the virus occurs in the periodontal pockets as periodontitis in high levels. So it can go in very high levels down in your sulcus and just hang out there. Herpes suppresses your immune system, which results in overgrowth of pathogens in your pocket now. So periodontitis, even if you have that, becomes even more severe. So the images of the condition below will follow. You've got your herpes virus 1, type 1. This is their primary herpetic gingivostomatitis. And you are on the recorded one. I could use a pointer. On this, I'm not able to use a pointer, but medical emergency words, you all divide it up to prefixes and suffixes, and anything with itis, you always read the last part first. So anything with an itis, I'll say, okay, inflammation. And gingiva, gingiv is the gingiva. And then they have an O when they combine two nouns like stoma, and gingiv is, they'll combine it all with an O. So it's gingivostomatitis. Stoma is anything in the mouth. Stoma means mouth. Gingivostomatitis is an inflammation of the gingiva in your mouth and around your mouth. Herpes labialis is when it's on your lips. Herpetic whitlow is when it's on your fingers, mostly your thumb. And you can get ocular herpes when it's in your eye. So this is primary herpetic gingivostomatitis. And you have mouth swelling and lesions. This is what it can look like. This one up here on the upper left also could look like what it looks like when the person has eaten a lot of really hard chips and it's just kind of scuffed the gingiva a little bit. So a lot of things look like other things, but so we have to know as many as they do and kind of put the clues together. Up here where you see the arrow, just keep going a little till you see those little marks up there. And this is herpes on the inside of the mouth. Healing with some remains of inflammation even 4 weeks later. So this is herpes labialis, different kinds of the virus. You can see when it's on the upper left, how it's just staying in a little circle with a few. The middle upper one is, you call those little vesicles because they are raised and it looks like there's, it's fluid, clear fluid on the inside. And so it will go from kind of nothing to those. It could be one big one. It could be many of them. They could be cascading, which means they're kind of coming down and follow each other down like that. So the upper right one is when it is, part of it is still oozing and part of it is crusted over. So this patient, until it's completely crusted over, I would go ahead and reappoint them. This poor fellow or young lady had contact with the herpes virus and rubbed their eye. So now they have herpes in the eye. Ouch. And this person over here just has it all over their mouth. This is herpetic whitlow. I would know that. It's herpes. These people, maybe they bite the cuticles on their thumb. They have that little skin that sometimes when you're fooling around that you kind of scrape right at that place, that upper right one, and they were around the herpes virus and it gets, now it's in their tissue. This person had the same thing on their finger, on the inside of their finger. So that's herpetic whitlow. Here's some more really bad cases. You can see it can get really gross, really, really bad. So the herpes virus disease is, okay, we're going to talk about herpes virus 2. It's commonly known as genital herpes. It may occur as oral or perioral. Anything that's peri means around. So it's around the oral cavity infection. And they usually use cold sore or fever blister, of course, for these. You postpone the appointment if that's full blown and contagious, which is right before crusting. Always confer with one of us before proceeding with the appointment. If you suspect it's, I don't care how many times you might be wrong, it may be something else on their lip. If you think it is, please come and get us. We do not mind that at all. Herpes virus, then we have the varicella zoster, which is VZV, or it's herpes virus it's a 3. And so one of the 8 kinds of herpes. So varicella is chickenpox, zoster is shingles. I would know that. Respiratory droplets and direct skin contact with vesical fluid is how you get it. And the primary infection of the chickenpox, is the chickenpox, and the shingles come out usually later in life. The shingles, the chickenpox always stays in your system, and you may not get that, but then people maybe in their 50s or 60s or 70s have a lot of stress, and they'll show up with shingles, and it can be on the trunk area. It's extremely painful, and it lasts for a while. The shingles zoster infection, which I'm talking about, it's a reaction of the chickenpox years later in the form of shingles. Then you have the Epstein-Barr virus. The Epstein-Barr virus is mono. We've all probably heard about mononucleosis, and it comes from the Epstein-Barr. I see that in review books all the time. It's infectious mononucleosis, and you transmit it by saliva. That's why they used to call it, I don't know if they still do, they used to call it the kissing disease. Then you have oral hairy leukoplakia. Plakia means like a patch, some kind of a form, and leuko is another word for white. So it's a white patch that looks kind of hairy. And people that have that if they already have an immunosuppression in their system. So these are pictures of varicella zoster, or the herpes virus 3. So here the picture is, you can even get it on your tongue. And then the chickenpox, of course, you can get everywhere, and that's what it would look like on that we would need to be looking at from an oral observation. So mono is 4 by the Epstein-Barr, and it can look like any of that in the throat. It can look like mumps almost. And one thing we're going to do, which we are going to start in the next couple weeks, are extraoral examinations, and you're going to be feeling all of those nodes to feel for bumps and lumps. If you pressed on this person's lumps right there, I'm sure it would be a little painful. So they're likely to have a sore throat, fatigue, and fever. This is oral hairy leukoplakia, and this we see on people's tongues. We can see it on their attached gingiva. You'll see it on the underside of the tongue, on the top of the tongue. Usually what this is from is some kind of irritant. And what happens is it keeps rubbing against the papilla on your tongue. And so the papilla, trying to protect the tongue, starts to get a little longer, and it's trying to roughen up a little bit in order to protect whatever's kind of attacking it. So it can look sometimes like almost hairy like that, but you cannot scrub it off. There's some white patches that we look at that you can scrub off. If you tried to take these off, there would be just a big red spot there that would hurt a lot. They could be white or gray on the tongue, gums, roof of the mouth, or inside of the cheek. It's from irritation of a rough surface of filling or denture. Smoking can cause it. Sun exposure to the lips a lot of times can cause that around the lips. HIV could cause it, or AIDS. And so if you remove the irritation, it usually clears up in just a few weeks. This is called, not to be confused like with the black hairy tongue. This is your papilla shed like every 21 days. So about every 3 weeks. There was bacterial fungus that had built up on the papilla, and instead of shedding, it grew longer. So that's why it looks like hair, the black hairy tongue. It could get the color from food or smoking, having a soft diet, being dehydrated. Some medications can cause this, and very poor oral hygiene. So you need to ask your patient to use a tongue scraper on a daily basis, or just brush over their tongue. Cytomegalovirus is the signs are identical to mononucleosis. I never have seen anything about this except that it's one of the 8. So we're not going to waste your time on it. Herpes lymphotrophic virus is 6. Never see anything about that. Human herpes virus is 7. I do see things about the 1, 2, 3, 4, and 8. Kaposi sarcoma, you'll be studying about later also in pathology, etc. This is AIDS related. It's related herpes virus, and it's herpes virus 8, which is Kaposi's sarcoma. This is what it can look like on the hand or on the inside of the mouth, on the outside of the lips. And this is from sexual contact. It's a malignant. A plasm is all a growth, and neo means new. So it's some kind of a new growth around the skin or the mouth, but it happens to be malignant. It could also be in your GI tract or respiratory tract. So this is what another picture of what the lesion could look like in the mouth. This is from an HIV positive patient with an intraoral lesion, but they also have candidiasis on top of the lesion. Candidiasis is a yeast or fungal infection that can be across your mouth and kind of look like cottage cheese. Usually only it's in, majority time it's in men, but sometimes can be in women. So I'm not going to go through each one of these. I think you have this possibly in your text of how it can spread. If you don't, you can come back and look at this. HIV-1 infection, general facts. AIDS is a severe pandemic caused by HIV, recognized back in 1981. So the transmission is through blood, semen, vaginal secretions, breast milk can transmit the infection, and of course, sexual contact. They do a serological test. Detection of the antibody in the blood occurs within 6 weeks to 6 months after the exposure to the virus. So the incubation period is possibly even 15 years plus before they'll actually start showing signs. So the majority of cases of transmission of HIV is due to what?
C.
Right. Sexual contact. I'd know that. That's on your study guide as well. No cases of transmission by saliva are known yet of HIV. So oral manifestations of HIV-1, extra oral examination, you could have purple, brownish macule or possibly a nodule, which is what they had. A macule is like a freckle. It's flat to the skin. It's not raised or anything. It's just flat, like a freckle actually is a macule. Also, so a nodule is something that is going to be raised and kind of like a little knot, something that's raised, or it could be under the skin and kind of poking out, but it feels hard. And so it can be in your lymph nodes, enlarge your lymph nodes. When you do an intraoral exam, you can fungal infections you'll see through the candidiasis, herpes, oral hairy leukoplakia, ulcers, oral lesions may persist for months. Bacterial infections, 2 to 3 millimeters of a red band, marginal gingiva, erythema, which means red. So you could have that's supposed to say band of, and it just lines, and we'll see a picture in a minute, and nug and nup. It does not, bacterial infections do not respond well to oral therapy. So this would be some pictures of candidiasis. It's like when you see it, you kind of don't forget it. It can be whitish to yellowish to grayish. It can be caused from stress, poor diet, suppressed immune system, HIV, some kind of toxicity, extended use of antibiotics. So if your older 70-year-old patient has this, who's been on constant antibiotics, it could be because of that. They are like, I don't know what this is and why it doesn't go away. So steroids, birth control pills, diabetes, rheumatoid arthritis, chronic fatigue, and high sugar and carbohydrates. And I kind of think with the high sugar and carbohydrates, it has to be piggybacked onto one of those other things. Or most people in America, we'd all have this, right? So this is linear because it's a line. Gingival, it's on the gingiva, and it's red. It's erythema or erythematic means red. So HIV, bacterial infection, and you can see I would describe this as this person has, or marginal. You could say linear marginal. It's at the margins and just keeps running in a line. Marginal, linear, gingival redness, which would on the upper anterior facials. And then you get a picture of exactly what this would look like. The left picture looks like it's a little worse. This is NUG. NUG stands for necrotizing ulcerative gingivitis. This is gingivitis on steroids. I mean, they're not actually on taking steroids, but I mean, it is huge. It's an HIV bacterial infection. You can smell this an awful way. You can kind of smell the disease a lot of times. These are pictures of different kinds of necrotizing means death. Something is being killed off, and that's what's happening to that tissue and the papilla in between the teeth. And ulcerative means that it's kind of depressed. It's looking like ulcers, and it's gingivitis. If you gingivitis, the gums probably hurt a lot. They're going to bleed profusely, like you just opened turned on a faucet. So when you're cleaning it. This is NUP. It's the same thing, only underneath the gum tissue. It's around the root, and so it's necrotizing ulcerative periodontitis. You can see this person has the same thing, only you can see how much recession they have. So all of that tissue and all the papilla is like destroyed. It doesn't even have any anymore in between the teeth, and the gum has receded and down and been destroyed, and you can kind of smell this as well. Dental management, when HIV is suspected from oral manifestations and symptoms, you refer them to the appropriate medical care. So we are ethically and legally obligated to treat HIV patients. And so you want to educate them to practice safe sex. And it may say this on something on your boards, but I don't know of a hygienist who tells their patient, and you will have them in your career, that have HIV to please practice safe sex. But as far as you need to try to educate them as oral things that can go on in their mouth. Maintain oral health as best we can and use standard precautions. Documentation, once again, you note the patient's medication and effects, record their consultations and referrals that you've sent them for specialists, and record the purpose and any lab values that may come back to you. So factors to teach them is to postpone the visit due to herpes infection only when in the contagious stage. You don't want them to touch or scratch the lesion. Avoid transferring the virus to objects or different parts of your body. Keeping medical history, the patient's medical history up to date, and always maintaining their oral health. You want me to go on, or you want a break? Is everybody asleep?
You can keep going.
Okay.
Yep.
So this is the exposure control and barriers. This should be a little more fresh to you since we've just gone over it. Exposure control, barriers for patient and clinician. Everyone needs to have, every office, every school needs to have a control plan. It is our professional obligation. Of a dental health care provider, any dental health care. Always use standard precautions, but that we always just assume that body fluids and tissues of all patients are treated as if they are highly infectious. And if we treat everybody that way, we'll be okay. Personal protection of the dental, we're going to go over that just a little bit again. We've already kind of hit it with the last, to make sure that you're immunized and do periodic testing, use PPE, personal hygiene, keep that up to par, hand care, and any kind of record keeping or documentation. So immunizations and periodic testing, you should have basic scheduled vaccinations, which you just went through with the, some of you with the hepatitis B. You can't even work in the health industry unless you have proof that you have this immunization, rightfully so. The booster and re-immunization about every 10 years for tetanus and diphtheria, annual influenza, hepatitis B series, mumps and measles and rubella, MMR, and varicella. So some of us that were vaccinated, 10 years or maybe 8 years ago and don't think about it anymore, you might need a booster that you're not even thinking about. So next time you go to the doctor, ask if your parents always kept a record for you, if you're still in your early 20s, it might be good to get that record and see if you were due anything. And for us older folk, we may still need something that we're not even thinking about anymore. So periodic testing, the annual recommended tests are definitely every single year you take a TB skin test. Every single year. So which of the following should be done annually? So obviously it's A, the tuberculin skin test. And they also, I kept this in here because I've seen some review books that won't say tuberculin test. They'll say I'm not even sure how to pronounce that. The Mantow test, and they'll say that. So I would just kind of know that that means the tuberculin test. Personal protective equipment, clinical attire, hair, face mask, eyewear, gloves, face shield, hair covering, These are all through the CDC recommendations. And this I put in here, these this website that were recommendations from before COVID. So I'm sure they, I mean, I know that because I've seen them, that they have even, of course, upped their recommendations, but you can see that we need to follow this. Clinical attire, use your gown or your uniform. Jacket, it needs to be free from contamination. It needs to have long sleeves and fitted cuffs. It should be separated from your household laundry if you are doing laundry. Outside considerations, when you come out of here, it is considered that your uniform is contaminated with some type of aerosols that maybe you didn't use it, but your next door neighbor used something aerosol, and they can stay in for hours, some of those, and they can be transferred. So that's why it's important. Hair and head covering, we have had these until we just came back. Now they're kind of hard to get. We have been using hair coverings. They're not real cute, but and we'll be getting some more. We need a clear field of operation. Your hair needs to be up off the shoulders and back away from your face. Facial hair is covered. If you have a beard or a mustache, it needs to be covered with a face mask and a face shield. Beard is a great way to collect any aerosols or coughing or sneezing from anybody. So it's just harboring anything in all of that hair. So is our hair, by the way. So if you're not having a hair covering and you're seeing patients, you need to be, I mean, to really not have contaminants on your hair, you would need to wash it daily. That's why everyone has just finally, succumbed to the hair, a covering your head. Because not everybody wants to wash their hair every night. Okay, so facial and respiratory protection, a mask efficiency. They have what they call BFE. It means bacterial filtration efficiency. And so that's how they grade the different kinds of masks into level 1, 2, and N95 or in K95. Vital to protect against inhaling droplets, nuclei from aerosols. The mask changed for each patient. You need to change it for each patient when it's wet, and when it's no longer, you don't wear it for any longer than an hour, and then you need to change your mask. So in private practice, this is not a problem because your patients are based that way on an hour or less. In the clinic, and when they mean wet, sometimes you can be those aerosols from, are getting on the outside of your mask. So when it becomes wet, you need to change it. You need to adjust the mask before eyewear and hand wash, and it's suggested to not twist the side bands because it makes an opening on the side that it doesn't fit so tightly against the face, and so aerosol can get in that way. You're going to grasp it not by grabbing the face mask itself, even though a lot of us can't get out of that habit, but you're supposed to grasp the side elastic strings. And I'll let you. So you put your fingers on both sides and take it off that way. Eyewear, dropped instruments, little pieces can ricochet off things and get in the eye. They have. People have had that gross fluid from the ultrasonic splash in their eye. Saliva, biofilm, aerosols, calculus can spatter up, can go into your eye and spatter from like your prophy paste or toothpaste. So patient protection, hopefully they have contacts in, and you want them to, that's why we want them to have our glasses on, is to protect from any kind of spatter. You want that to be wide. Types of eyewear, goggles, side shields. You want to rinse them with water and air dry them. Do not use your goggles as a headband and put it on top of your head. The eye wash station is for lavaging your eyes, and we have green caps and red caps. We have 2 in the our clinic. They're separating ops 3 and 4, and they're hooked onto the sink, and they're separating ops 9 and 10. So that's an eye wash station, which we'll go over. These are different types of goggles. Hand care, bacteriology of the skin. Your skin breaks and anything can get in there. Fingernails need to be short and well cared for cuticles. Jewelry, only the wedding and engagement ring. Watches, if you're going to wear a watch, it needs to be cleanable. You need no cloth wristbands. Any of that contaminant can get right on your wristband. So other jewelry should be kept at bay. We did for a while say no other jewelry. We're allowing you to wear like a choker necklace, but just make sure you're cleaning it at night when you go home. And any earrings that you have, you want to kind of clean over. But if you wear a necklace, it has to be like a choker and with a really small something there, not a big necklace. Okay, after hand wash, you're going to don the gloves. After glove removal, you're going to wash the hands. You're going to see the word don gloves, which means put your gloves on. Doff, D-O-F, means to take your gloves off. And you're going to see these words throughout dentistry and healthcare industry. They'll say, don your gloves now. Now you may doff them instead of take them off and on. So after you hand wash every time or use antibacterial gel, before and after glove, before you put your gloves on, after you take them off. So they are the CDC guidelines of 2002. I'm sure they have the guidelines of 2020 now. If they don't change anything, they'll, in the next 8 years, they'll still call the guidelines of 2020 until they make changes, and then they'll adopt that year. Hand washing is to reduce the bacteria flora and transient bacteria. I would know that. You want to reduce the flora that naturally is on our hands and any bacteria that we might be a transporter of, just something else. So facility, you'd like to have a foot-controlled sink or use paper towel to turn the faucet off. Do not lean against the sink. You need to disinfect often around the sink. It's a very dirty place. So the agents, you can use soap, can still use liquid surgical scrub containing antimicrobial agent, but they are saying now that wondering if there's bad things in antimicrobial agents, so we still have to wait and see what the judge and jury says finally about that. Before and after each patient, you hand wash before glove placement and after glove removal. Esther Wilkins, who is the author of all of Hygiene's the clinical books, states that hand washing is considered the most important single procedure for the prevention of cross-contamination. It's just washing your hands. So methods of hand wash, I'm not going to go through these in particular like we did. You can go through them. It's exactly what you did during your assessments, and there's a group that still needs to go through this. Surgical antisepsis is usually when they say anything surgical, it means a 10-minute scrub. When guys are going, you've seen on shows when they go into surgery, how they go in and you have to have your elbows. They want the water to run down off the elbow, not to have their hands like this. That's why they always have their hands up, and they put on surgical scrub, and they have to scrub for like 10 to 15 minutes, but usually for all of our purposes, I usually see a 10-minute. We don't have to do that because we're not doing surgery, but you need to know what that is. So hand washing method, here's the hand washing method that we use in our clinic. There is a discrepancy between OSHA, which is hugely important to listen to, Occupational Safety Hazard Association, and the CDC, Centers for Disease Control. They both, one says 15 seconds and the other says 20 seconds. So we're just saying hand wash for 15 to 20 seconds. And you want to be able to get your paper towels out of a place to where you're not contaminating everything Gloves protects the patient clinician. Its criteria for selection would be you want a glove to be impermeable to the patient's saliva, blood, and bacteria. It needs to be of some type of strength and durability and non-irritating. They do have gloves that have powdered on the inside. They make gloves out of latex and nitrile, which we have nitrile, which is non-latex. And there are big allergies for some people with that. So that can create hand issues. And ergonomic factors. You don't want a glove like those patient gloves, like we have our blue gloves, to be too tight because it is going to wreak havoc with your bones and your muscles at a later point. So utility gloves are heavy duty plastic gloves. We have those. They're food handler gloves that can be worn as an overglove on something. Gloving technique, you want to put your gown or lab coat on first, your mask and eyewear placement, your hand wash before the gloving then, and your glove placement. You want to do your glove placement in front of your patient, and then don't touch anything you don't have to for treatment. So I've done this before. I have them on. I have this really bad itch on my like temple, and so I will go like this, and then those gloves get taken off in front of the patient so they can see you've accidentally touched something and now you're removing it for new gloves. Glove removal in front of the patient, and wash your hands in front of the patient. We had them stop us and say, I don't think I saw you wash your hands. And like, yes, I did. I washed it kind of behind you. You need to do it in front of them. You never leave your operatory with your exam gloves on. The only exception is when you transport prostheses, which is a denture or something like that. You don't need your utility gloves. You can just do that with examination gloves, but it's the only time you should be doing that. Factors affecting the glove integrity, they can be torn, cut, or punctured gloves. You don't want to wear them more than an hour without changing them. We do a little longer now because they're being very difficult to get, and we need to have gloves. Sad reason, but it's reality of the COVID days. The size of the glove, you need to have it not too tight or not too loose because you'll lose your tactile sense, which is feeling and palpating. The agents used in care provision, if you have latex gloves, you don't want to use Vaseline or put chapstick on the patient's mouth, or use alcohol rub with them because it ruins the integrity of your glove. If you, even on nitrile gloves, if you take a cavicide wipe and use it with your nitrile glove, with it can soak into your system, and doing that over and over and over and over can create issues with your liver. So that's why another reason that we like people to have on utility gloves when they're cleaning. And people have done it forever with just exam gloves in private practices. But at any rate, now you know. Agents used in care provision, no Vaseline, chapstick, or alcohol. Hazards, if you have rings or jewelry that can create tears, or long fingernails. Latex sensitivity, your patient, there's 4 types, and actually I think there might be another one, but we're only interested in hygiene and hypersensitivity type 1, latex sensitivity type 1 and 4. Type 1 is when you have latex gloves on, or there's something with latex in your office, and they get this immediate skin reaction, or they have such a severe reaction that they're going to get an anaphylactic reaction and their throat closes shut. So that would be an immediate reaction, or hives immediately or something. Or you can have the type of person that has type 4 sensitivity. That's a delayed reaction. They go home and maybe 6 hours later or the next day, they'll call your office and say, what in the world did you use on me? I am completely broken out. Or I had a delayed reaction and I had an anaphylactic reaction, had to go to the hospital. I backtracked everything that I did, and I think it was something in your office. Okay, so you can have a delayed reaction. So that we always put alerts on there and document any kind of latex allergies. Individuals, maybe they don't know that it's their first time to a dentist or a dental hygienist. That happens a lot with older adults. A lot of people are from different countries and they didn't, anyway, this is their first appointment. When they're doing their medical history, and then we have a section on allergies, if they mark in there that they're allergic to avocado, bananas, kiwi fruit, chestnuts, or papaya, a lot of times those with frequent exposure to those will develop a allergy to them. And they will say, no, but I'm allergic to papaya or chestnuts. Now, some of them won't offer that information because obviously they don't think it has anything to do with the teeth, cleaning your teeth. So on their medical history, if you say they list a food allergy, you can say, do you have any other food allergies like bananas, chestnuts, avocados? Oh yeah, I'm kind of allergic to avocado. Okay, so a lot of times those are the people that also have a latex allergy. It's not always, but a lot of times. So those who have had multiple surgeries like spina bifida can have a latex allergy. They've been around exposed to a lot of things in surgery. So the clinical management for someone who is our early morning appointments before there's a lot of stirring up of anything in the office, and have latex-free gloves and be on alert for some type of an emergency. So people at high risk of developing latex allergy, and it would be D. And I've seen this actual question in review books and a review course that I took in January for boards. So anyway, I would stick that in the back of your brain because I know you don't have anything else to stick there, right? Okay, sterilization. If we can get even through sterilization, the ergonomics, I think you can handle on your own. I'm not going to be able to talk for a week. Okay. Infection control and clinical procedures. So I'm not going to go through this. We already did. Treatment room is your dental chair, your unit, your light, your stool, the floor, the sink, the supplies, and the waste. That's a treatment room or an operatory. So most of them have these type of, this is how it's going to look. You have to have a place for biohazard waste. On a waste can, you need to have a sink fairly close to you with foot controls, sharps container somewhere close to you, and all your supplies sterilized or disposable. Your foot controls. The thing about this is that if they ask any questions about your chair or your patient's chair, you need to have something with no seams, that where bacteria and bacteria can hide in. You need to have that's the best kind of a patient chair, and they need to have barrier covers, etc., and really easy to clean. You need to be able to clean the hoses, and your hand pieces and whatever need to be disposable or autoclavable, and your light handle needs to have a barrier cover. So instrument processing center, which we've spent time in, and we'll get the other groups on Monday. You have an instrument cleaning area, you have an instrument packing area, and then you have a clean side. So you have a dirty side, a packing area, and a clean side. And you need to wear full PPE even in the sterilization room. And so this is one of them. You should have an in and an out so people aren't coming in and out. You'll see it happening. We get in a hurry and then you think, I shouldn't have come in that way. Just remind yourself and and make sure that you're trying to go in the right way, okay? Because it happens to all of us, even the dentist. So we want to go in the inside. That's the dirty side, and the packing, and then onto the instrument cleaning, which is the autoclave. And then we have the whole other area, which is the clean side. Okay, so instrument, we did have an instrument like a dishwasher. It's called a thermal disinfector. It was really cool. It kept breaking down because it just was running constantly. And we probably had it maybe a good 5 to 7 years. And then it just was breaking all the time. It was more expensive to fix it. And we finally just took it out. So then we put the ultrasonic back up. The ultrasonic is safer than manual cleaning. It's not a substitute for sterilization. I would know that. It is a cleaning process. Manual cleaning, you're always going to have utility gloves on with long handles. Instrument packing is where you're trying to prevent contamination. Use the cassettes for your arrangements or trays or packages for your instruments, and mark whichever one you choose. They need to be clearly marked on. You always are going to follow the manufacturer's recommendations for anything that your office or the school buys. We want sturdy wrapping. We need chemical indicator tape is required by the CDC, and we do not unwrap them until we are in front of the patient. So we saw these when we were doing our instruments. You have that striped tape, and the left side is not sterilized yet. The right side is. You can see the black lines. So approved methods, you have moist heat, which is steam under pressure, dry heat, and chemical vapor, and they're all approved. You must provide complete destruction of all microorganisms, viruses, and spores without destroying your instruments or the materials. So that is what causes, and whatever your specialty is going to determine what kind you buy. Tests for sterilization, you need an external chemical indicator, and this is used to seal the package and change color to show the temperature has been reached. Okay, so the internal chemical indicator you place inside a kit to show that the steam and temperature has been, that little tab that we wrote on, or that we put inside the cassette, or put inside that little strip. What that is going to show is that the steam and temp has been kept up for the required amount of time. So that black just means on the tape, just means that the temperature that we need to be at has been reached. So then once a week, you do a biological monitoring test that tests the autoclave in and of itself, just the autoclave and we have to send all of that stuff in. So moist heat under pressure, we use this one. It's the most often used in private practices. Principle is it works by action of heat and moisture. So you pack the autoclave loosely to permit the steam to reach all the instruments. Temperature must remain at 250 degrees for 15 to 30 minutes. Most of the time it's 30 minutes. We don't put oils or waxes or powders that the dentist wants to use. Usually don't do well in moisture. You can see steam under heat. It would make the oils and waxes into kind of mush or powders. So they usually will use a dry heat for those type of things. Sterilizer. So you want to maintain the proper amount of distilled water, wash the trays, weekly flush the chamber discharge system, which we do with cleaning fluid, and spore testing is that biological spore testing once a week. So the advantages of steam under pressure: all forms of life are destroyed quickly and efficiently, and a wide variety of materials can be treated without destroying the materials, and it is the most economical. So sterilization is achieved by action of heat. The pressure serves only to attain the high temperature. Then you have your dry heat. What you want to know about your dry heat I see questions about this in review books about steam under pressure and a dry heat sterilizer. It's the longest. That dry heat that you would put powders and oils in, and maybe really small little metal instruments, that anything that can't be sterilized in the steam with moisture. This is the very longest. Imagine if your office needed instruments and they weren't done for 2 hours and then they still had to dry. Okay, so this would not be, it's great though, because it doesn't corrode any of your instruments. And one thing that happens to our instruments and steam with our autoclave is that after a while, if they remain wet in there and don't completely dry, it can make a little rust on our blade. But you can remove that easily with a just rubbing alcohol and gauze strips. Just take quite a few so you don't cut your finger open with the blade. So the length of time makes dry heat impractical for all processes unless they have a specialty office where it works okay for them. Then you have chemical vapor. Chemical vapor is not great either because they combine alcohol, formaldehyde, ketone, water, acetone, and they heat it under pressure to produce a gas. And the gas is actually the sterilizing agent. It does have microbial and viral destruction. Heavy, tightly wrapped packages, though, would not permit the penetration of the vapors. They will permit penetration of steam under pressure like we use, but it doesn't permit it under vapors, so they cannot package things the same way. It's really the greatest amount of time, the shortest amount of time. They needs to operate at 270 degrees and for 20 minutes at a minimum, 270. So the disadvantage, and it's a huge disadvantage, is that you need to have a place that has adequate ventilation. And it says there's a slight odor. It's a yucky odor. It's not slight. It can't be used in a small room. I mean, it just stinks like all those things being heated. And so you've got to have a large place that can ventilate for those. It is corrosion and rust free though of carbon steel instruments, and it only takes 20 minutes, which would be great. But the smell is what makes it impractical for most offices. Care of your instruments, you are going to, okay, I was looking at the time, I thought it was 4. Instruments without sealed wrappers are only sterile momentarily due to airborne contamination. That's why we don't open them until we're in front of the patient. Now, private practices a lot of times do it differently. They'll have a stack of trays, a lot of them, and they'll get the instruments out. Some of them even open the instruments and lay them on their tray, and then they put floss and everything else that they'll need for the appointment. They'll open up the bib and place it over the top of it like a little cover, and then they put it in the stack, and then they have like 8 patients worth of instruments ready. So you can do that with other things, but if you're going to do that, you need to leave your packet of instruments on like put together so that you can at least, so every patient, especially now in COVID, but I think it was always important that they know that you're using brand new items. Okay. I also wouldn't put those just on a tray with paper or something by itself, because when they come out of the autoclave and get put on the clean side, what's in it is sterile, but the outside is quickly not sterile because everybody is turning it over to see what it is. There'll be certain people that will say, I'll put your instruments away. Then another person has touched it. It is not sterile anymore. So then you go put it on your tray, and then you open up your instruments and dump those on the tray. So, okay, so you can see what the issue is. I would put those on in our clinic. I would put them on the cabinet countertop. until you're ready to use them. And then open them kind of, you know, if you ever have your instruments on something else, open them and put them on your tray. So you need them labeled, sterilized, sealed packages, or stored unopened in a clean, dry cabinet or drawers. The shelf life is usually up to a year. That's why we date stamp them. I told everybody that that's what we were doing, that was able to go through the sterilization part. In our clinic, we do every 6 months, but on tests, our board questions, the shelf life of a wrapped or sealed package or cassette or whatever is up to a year for several months, but it's up to at least a year before, even if no one ever used it, you'd need to repackage it and rerun it through with a new date to make sure it's still sterile on the inside. Plastic or nylon wrap with tape or heat seal is sterile for just a while longer. So which of the following is an autoclave? You would always answer steam under pressure. So one thing I wanted to talk about before we go is with one of the groups yesterday, we were talking about the use of utility gloves, and those utility gloves being taking the clean side instruments with utility gloves back to a operatory. And I think okay, so there's a part that you need to know for your quiz, and there's a that's talking about when you use utility gloves. So let me see. I think I just got really confusing I knew what I meant. I wasn't expressing it very well. So this is the skinny on that. You need to use utility gloves anytime you are setting up your op. And that means that when you go into your op, it's not already set up. So you would need to start cleaning, okay? And we don't do that because we set it up the night before. But a board question or a test question doesn't go into that much depth. They're going to be thinking you're going in and cleaning and disinfecting your office. Okay, so you are going to wear utility gloves to set up your operatory, to tear down your operatory, and to always, when you have contaminated instruments, you always use them contaminated. So now let's say they run through the autoclave and now they're on the clean side and they need to be put away. You do not have to wear utility gloves when you take those to your operatory. What I was saying was if people are using those packets in a really haphazard way that the explorers or sharp instruments will poke through, then they probably will want to have clean operatory gloves to even transport those. My suggestion would be, this is just me and I think it makes sense, is to go get in that drawer that you all saw, get one of those grayish trays and put a lot of those on the just bags with the sharp instruments that could poke out on those trays and transfer it that way. If it already is poking out, you need to repackage it and re-sterilize it because now that tip has touched the air and it is not sterile anymore. But when you are taking things from the already sterilized area and you are careful with what you're carrying, you may carry those, you may, put hand sanitizer on and just carry those with your clean hands. Okay? So if you have any confusion about that, email me and I'll try to unconfuse you. I think there's a group that I totally confused, probably because I was talking so much I didn't even know what I was saying anymore. Okay, so That's the deal. Okay, so chemical disinfectants, you can have several forms. You have a surface disinfectant, you have immersion disinfectants, like an immersion disinfectant would be our ultrasonic. You have immersion sterilants that will sterilize whatever is in that immersion liquid or whatever. And you have hand antimicrobials. Disinfectants, they're all categorized, and this is for doctors also, the hospitals do this as well, are categorized by their biocidal activity. Cidal means death. That means they need to be killing any biomaterials in there. So you have high levels. Hospital is usually, you have high levels, you have intermediate levels, and you have low levels disinfectant. So biocidal activity refers to the ability of a chemical disinfectant to absolutely destroy or inactivate any living organisms. And we have high level and intermediate level. Some offices have all three for different things. So chemical disinfectant, high level, I would know this. High levels inactivate and destroy spores. And they all do some form of bacteria, fungi, and viruses. But the difference is that a high level will destroy spores and everything else. It's either a disinfectant or it can be a sterilant put in some kind of a liquid that you're going to immerse something into. Your intermediate level, which could be a spray or whatever that you're using, can disinfect, inactivate all forms of microorganisms, but they don't destroy spores. That's the difference between high and intermediate level. Then the low level is a disinfectant that it inactivates vegetative bacteria and certain lipid or protein type viruses, but they do not destroy spores or TB, tuberculosis bacilli, or non-lipid viruses. So sometimes around your house, there's certain things that you might want that for, or around the office. High level destroys spores. Intermediate does not destroy spores, but does the other microorganisms and viruses. Low level does not destroy, it really inactivates vegetative bacteria and certain lipids, but nothing else. So I'll let you go through all that. Lot of the board questions will have, like, here's an A sentence and a B sentence, and they'll have this: A is correct, B is not correct. And we don't, seems like we've heard that they're getting away from a lot of those. Used to be a lot of them, and people complained so much because they're very difficult to answer for some people. So we still put a few of these on here for you to get used to seeing them. But the last few boards, we heard that they were going to take a lot of these forms of questions away, but they're still going to have some. So we're going to continue to see it. Criteria for chemical agent selection. You need to select something that's EPA approved. Use EPA registered hospital disinfectant with a tubercidal claim for intermediate and high levels, especially when there is visible blood or other potential infectious material. It has to be tubercidal, virucidal, fungicidal. A label on it has to say what their shelf life is, what its use life, its reuse life, type of container for the storage, where to place it in heat or light, instructions for disposal, warnings, and direction for use. So this is one of the things I wanted to get to before we quit. An ideal disinfectant needs to be these things. So you don't have to memorize these, but I would be able to recognize them. If your boss said, go buy us a new disinfectant that we need for our office, you would want to be you want to get something that's broad spectrum, that works on a lot of different things, kills a lot of different things. You want it to be fast acting. You want it to be active in presence of organic matter, such as blood, sputum, and feces. Be able to kill that. You want it obviously non-toxic for someone to breathe or get on their skin. You want it to have surface compatibility, that it's not going to ruin your leather chairs like Cavicide can. and with repeated use. You want to have a residual effect on treated surfaces. So we need to be when it dries, you need to be, you want to be able to see if it's going to have a lot of stuff left on there that your patients are going to get on their clothes. You want it easy to use, easy directions. You want it odorless, not to have a really pukey smell. And you want it to be economical. Get something that you can get all those things with that is the most economical. So I am going to leave it there. See if there's anything else in there that I really want to point out that we haven't already said. Already said that. This is on if you kind of have sticks, occupational exposure management sticks. With if you're getting a needle stick and there's a certain protocol that's always followed, or every office should have a protocol for office sticks. We have this in our clinic. We have everything that needs to be signed and where it needs to go and who needs to pay for it. And like if you get one, our school will pay for it to be done, etc. It needs to be and have a follow-up. We already kind of talked about regulation of disposal of waste and biohazard. This is the universal label for hazardous material. I've seen this in review books. And that would be it on that. Okay, so I hope you're okay with the fact that we're not going to go through ergonomics. I think you can go through that. But one thing I wanted to go through, and if you want to, before you leave, because you can leave right now, I mean, in 6 minutes, anything else on your study guide that you didn't find answers for? Anybody?
I have a question, but it's not about the study guide.
Okay.
It's about the homework. So like the iodophores and the chlorine compounds and stuff. Do you want us to just look those up on the internet? Because I can't find that in the book anywhere.
Yeah, they've taken a lot of that out, but I've noticed on review questions that they'll talk about iodophores and all that. We don't really talk a lot about it. So I just want you to be kind of familiar with it. So yeah, I would go to a reputable site and ask about like what those are. Just kind of a brief. It doesn't have to be long.
Okay.
Or say examples. You could Google what are examples of iodophores, because otherwise it won't stick in your head anyway. Anybody else?
What homework is she talking about?
One of those sheets. Which one is it, Clara?
It's that paper you gave us that looks like this.
Yeah, about the sterilization. Yeah, the sterilization one. Yeah. Okay.
Okay. Yeah.
Anybody else? You're good with your study guide?
I know a few of us looked this one up on Google, but question 16 on the study guide that says static loading, is there like specific answers for that? Or just like the stretches? Because I know we have the picture on PowerPoint.
Let me pull it up.
I think it was slide 28, but I didn't know if there was like specific like names for the stretches and exercises.
No, There's not. It just means that certain things that you could do that you could, it would be exercises, but you could say you could do hand exercises. You could do, stretching when you can, even at your seat, to help prevent static loading. And static just means because you've been sitting in one spot forever. So, and you're not getting up. So you can kind of roll your ankles, but that you can do, you can take breaks often is what they say in the book. So it might be on a board's question, but anybody in a dental office that has had experience would die laughing at that. Most of the time you do not have much of a break to be able to count on, but they do say take frequent breaks, or just try to stretch out or do hand and wrist exercises. Yeah, so it's like that.
Okay, thank you.
It would be these. And I'm not sure, does it have? So the best ways that you want to sit is, and I'm wondering if it had a, okay, this question right here. Which of the following is not a correct positioning for a clinician in a neutral position? What would you say?
A.
Correct. And the reason I say that, I've seen this in quite a few, just stated exactly this way, and in quite a few review books. And a lot of people get it wrong because they're reading so fast, since there's a lot to read before they can answer it, and they don't pick out that word perpendicular. They think of it as being, shoulders should be relaxed and parallel. They just go over it because the shoulders should be relaxed and parallel to the floor with your hips. But that question says your shoulders are relaxed and perpendicular, which means you'd have to be seated like this for your shoulders to be perpendicular to the floor. So I'm just wanting to point that out. And all the rest of those are true. You see elbows close to the body, parallel with everything in a straight line. And the 15 to 20 inches, I would know that, and that's what you're going to need to do. Get comfortable in your position with your patients before they come in and want to get you loops. Because they'll measure. And at first, so many people have their head forward. I was explaining to one of the groups yesterday that if you did that early, your inches would be totally off on your magnification. And they are so expensive, you don't want that to happen. So we always wait a bit for you guys to learn about it first, and then start on patients, and have a few weeks to see where you kind of normally have your head, and then call them in so you can get your loops. So do you understand with the Trendelenburg, when people faint, how you're wanting to have the head lower than the heart and the feet, because you want all the blood to rush to the head so that they will, because what fainting is the loss of blood in the brain area. So you get so lightheaded, and that's why you want the blood to go. Anything else? No? Anything else you want me to go through?
Wait, when's this quiz for the study guide we're going over?
The quizzes are going to be on Monday.
Okay.
Is that good? All right.
Yeah.
So it'll take a while for this. This is a long recording, so it'll take a while for this to download, but I will have it up as soon as I can get it. Okay?
Thank you.
Thank you.
You guys have a good
you.
rest of the evening. If you have any questions, email me.
All right, thank you.
All right, bye.